Dear students, so today in the online sessions we will learn about the inflammation and repair. And today particularly we will learn about the acute inflammation. I am Dr. Rahul Modi, Assistant Professor in Department of Pathology, and I will be teaching you inflammation and repair. So at the end of the sessions, you all should be able to write what is inflammation, describe the types and causes of inflammation. Types are particularly acute and chronic, and there is a peculiar type of chronic inflammation, that is granulomatous inflammation. You should be knowing enumerate mediators of inflammation, right mechanism of chronic and granulomatous inflammation, describe wound healing and repair. So the clinical signs of the inflammation, we will start with this picture. You can see the edematous lower limb toes and thumb, and you can see the red colored. So these are the clinical pictures of the inflammation. We will see why this kind of picture happens. So this is again a redness, edematous hand. We will see this is acute pharyngitis. There is also suppurative tonsillitis. So the cardinal signs of inflammation, first is the calor, that is heat, rubor, that is redness, tumor, that is swelling, dolor, that is pain, and functional is a loss of function. These were coined by the Celsus. The calor, rubor, tumor, and dolor were coined by the Celsus in the 1st century, and later on by the Rudolf Virchow, the functionalism was added. Functionalism means loss of function. Acute inflammatory response. The clinical indicators are generalized malaise, fever, pain, rapid pulse rate. There can be the laboratory findings of the inflammation, that is raised neutrophil count in the peripheral blood, increased ESR, that is erythrocyte sedimentation rate, increased acute phase proteins in the blood, that is increased greatly, and that is induced by the interleukin-1 and produced by the liver. C-reactive protein, that is again produced by the liver, CRP, and that is also a important protein that increases in acute inflammation, and that is used to monitor the patients in the acute myocardial infarction. So you can see the neutrophils in the acute inflammatory processes. Neutrophils aggregate at the site of the inflammation. So this is the repair and fibrosis after all events of inflammation. So now the definition. So what is inflammation basically? Inflammation is a protective, rapid response to an injury intended to eliminate the causative agent as well as remove the resulting necrotic cells and tissue resulting from the original insult. Now, is inflammation and infection same? No. Inflammation can occur in non-infectious conditions also. Infection is microbial infection by the bacteria, viral, that is called infection. But the inflammation can be due to non-infectious conditions also. So it is not the same. So which are the agents that can cause inflammation? These are trauma or radiation, microbes. Microbes can be bacteria, virus, fungi, toxins, any chemical injury, drugs, etc. After the agent is removed, repair also has to take place. This is done with the help of the parenchymal cells or by the fibrous scar tissue. Now, can inflammation be harmful? Yes, of course, inflammation can be harmful in certain conditions. Like when repair takes place, peritonitis leads to the formation of the fibrotic bands and then can lead to the obstruction. Anaphylactic shock, that is very important. Anaphylactic shock can be the cause of shock and death. Atherosclerosis, this is also one kind of inflammation, and the lipids in the bloodstream form the plaques in the blood vessels, and that can again cause the ischemic diseases, and particularly it can cause myocardial infarction. Pericardial inflammation, that is fibrous encasing, impairs the cardiac function. The inflammatory response has many participants like circulating agents, plasma proteins, clotting factors, kininogens, vascular cells, endothelial cells, connective tissue, collagen and elastin, mast cells, macrophage and fibroblast. In short, what happens in inflammation response is first inflammatory stimulus is there, that is injury, that can be microbes, that can be radiation. Release of the chemical mediators from the plasma or connective tissue, amplification of the inflammatory response, leading to cellular and vascular responses, decrease in response when stimulus is removed, and inflammatory mediators are catabolized. Now, inflammation. Mainly, we can divide the inflammation into two types, that is acute inflammation. Acute inflammation is of short duration, few minutes to few days, fluid, plasma proteins with predominant neutrophils, and the chronic inflammation is long duration. The lymphocytes, macrophages, vascular proliferation and scarring, this all goes together. So, and there is a particular type of infection that is inflammation that is called granulomatous inflammation. That is again a chronic type of inflammation, and it occurs mainly in the tuberculosis. If you see the infectious agent, that is the Mycobacterium tuberculosis, and you will find the granulomatous inflammation with the caseation necrosis in case of tuberculosis. So this is the slide showing the acute inflammation microscopic picture. You can see the plenty of neutrophils. Acute inflammation definition. It is the immediate and early response to the injury designed to bring leukocytes and plasma proteins, that is antibodies, to the site of injury along with local vascular reaction, and which is insufficient to kill the tissue. Causes of acute inflammation. So, as I already told you, it can be infectious or non-infectious. Infectious agent, bacterial, viral, fungal, parasitic can be there. There can be tissue necrosis due to hypoxia, trauma, chemical, physical injury. It can be due to foreign bodies, sutures, suture materials, and it can be the immune reactions. Now, mainly two changes are there in case of acute inflammation. First is the vascular, second one is cellular. Vascular changes are, two changes take place, vasodilatation and increased vascular permeability. So the changes in vasculature are, initially there is vasoconstriction, but later on there is vasodilatation, which is responsible for the redness and warmth seen in the inflammation. And the culprits are histamine and nitrous oxide act on vascular smooth muscle cells. Then there is increased vascular permeability leading to the oozing of fluid outside the vessel, resulting in increased viscosity and slowing of circulation. So the RBCs get packed and there is stasis. So this is the vessels, normal, the above picture shows the normal condition. You can see the in inflammatory response, there is vasodilatation. You can see the increase in the extracellular fluid matrix and the neutrophils. The WBCs also start accumulating, which is called margination. They squeeze out through the endothelial cells lining the blood vessels and enter the interstitial spaces. The endothelial cells are activated by mediators and they express adhesion molecules. This leads to the adherence of leukocytes to endothelium and later on migration into the interstitial tissues. Increased vascular permeability, increased vasodilatation, increased intravascular hydrostatic pressure, fluid moves out of the capillaries resulting in an infiltrate called transudate. So there can be transudate or there can be exudate. Now we will see what is the difference between transudate and exudate. Later on the increased permeability results in what is called exudate, that is protein rich fluid. Fluid increases in perivascular space, resulting in increased osmotic pressure in interstitium and decrease in vessels. This causes water and ions to outflow, resulting in edema. So this is the difference between transudate and exudate. Transudate is cardiac and renal failure. It is basically it occurs in non-inflammatory conditions, while peritonitis, pleurisy, in these conditions you will find the exudate, and it is mainly inflammatory in nature. Due to inflammation it occurs. Increased intracapillary pressure can be there, increased permeability of the capsular endothelial cells in case of exudate. In case of transudate, clear transparent pale yellow fluid, while the exudate is turbid and hemorrhagic, and due to that it is having increased specific gravity. Specific gravity in transudate is 1.006 to 1.010, that is lower than exudate. In case of exudate, it is 1.018. Coagulation, spontaneous coagulation cannot occur in transudate while it is present in case of exudate because there is a fibrinogen content in the exudate. Protein is 0.7 to 0.7 gram percent, while in case of exudate it is 3 to 4 gram percent. Cell count, it is very few in case of transudate. 100 cells per cubic millimeter can be there. But in case of exudate, the cell count is more. You can also find the RBCs. You can find the plenty of polymorphs and lymphocytes. Bacterial organisms generally absent in case of transudate, while in exudate it is present. The changes that take place in the vessel wall, seen more in venules, presumably due to the fewer receptor for the chemical mediators which help transudation, is as follows. Endothelial cell contraction. That is, due to the endothelial cell contraction, what will happen? The increase intercellular gaps. There will be increase in the intercellular gaps. This is due to histamine and bradykinin and leukotrienes. This is very short-lived, only 15 to 30 minutes of event. Immediate, transient, reversible, and it is reversible mechanism, immediate, transient and reversible mechanism. Now the endothelial cell retraction, increased vascular permeability, due to that the cell junction is disrupted and it mainly occurs due to tumor necrosis factor and interleukin-1. It takes longer to develop, that is 4 to 6 hours, persistent for long time. Direct endothelial cell injury is the third event. 4 is the leukocyte dependent endothelial injury due to release of toxins. Increased transcytosis can be there due to the formation of uncoated vesicles, and there can be leakage of the new blood vessels, that is angiogenesis. Now what is the summary? This is a summary of the vascular events. First is the trauma and injury, that is the agent causing the inflammation. There is momentary vasoconstriction. Then there is persistent vasodilatation that can last up to 15 to 30 seconds only, and red irregular zone can be there. This is called rubor, there is redness. Blood flow increases, temperature rises, that is calor, temperature is increased. There can be increase in hydrostatic pressure. Contraction of the endothelial cells, separation of the intercellular junctions. These all events are due to histamine, interleukin-1, tumor necrosis factor, and INF. Increased permeability, there is transudate, then there can be exudate, increased viscosity of blood, and there is stasis of blood flow. Cellular events, margination and rolling. These are the cellular events now. First is the margination and rolling, adhesion and transmigration, chemotaxis and activation, phagocytosis and degranulation. So this is basically mainly the cellular events. You can see in the first the neutrophils are tethering and rolling. That is again by the mediated by the selectins. There is activation, that is by the chemokines. There is firm adhesion, and there is transmigration through the capillaries. Cellular events. Cells involved are red blood cells, white blood cells, and platelets. So first is the margination and rolling. Now these are the cellular events. Cells are normally placed centrally axial, but when flow increases, the slower moving WBCs are pushed to the periphery and they start adhering to the endothelial cells. This is facilitated by the selectins, E-selectin, P-selectin, L-selectin. Basically, they are present in endothelial cells. P and L are present in the platelets and leukocytes also respectively. These selectin are present normally intracellularly But when stimulated by histamine and thrombin or interleukin-1 or tumor necrosis factor, they come to the surface and facilitate the adherence. The cytokines are secreted by cells in tissues in response to microbes and other injurious agents like cell-like macrophages and mast cells and endothelial cells. So you can see in the capillaries there is normal flow, but the RBCs can be now of Rayleigh formation. There is margination of neutrophils, there is addition of platelets. Endothelial cell, leukocyte adhesion molecules, fibrin, platelets. You can see in the insert picture. There is pavimenting of neutrophils, endothelial cell adhesion molecules. So this is again rolling, integrin activation by chemokines, stable adhesion and margination through endothelial cells of the neutrophils. So second step is adhesion and transmigration. That is due to diapedesis, i.e. movement of the WBC through the basement membrane into the extracellular space. This is mediated by the immunoglobulin on the endothelial cells interact with integrins on WBC. There can be ICM and VCM, that is intercellular adhesion molecule and vascular cell adhesion molecule. Tumor necrosis factor and interleukin-1 induces their expression. What is transmigration? That is the leukocytes in the venous facilitated by the PECAM1 and by secreting the collagenases which degrade the EC junctions. Chemokines stimulate the cells to migrate through the EC junctions toward the site of injury. There is chemotaxis and activation also. After shifting from the blood vessels, the WBCs move towards the site of injury. This is called chemotaxis, and it is due to the chemotactic molecules. That is soluble bacterial products, component of the complement system, products of the lipoxygenase pathway of arachidonic acid and cytokines. Now the method of the action is the chemotactic molecules bind to the receptors present on the cell surface, resulting in the G protein mediated activation of the phospholipase C. Hydrolysis into the phosphatidyl ionocetyl biphosphate, that is PIP2. Now the PIP2 can also be converted into DAG, that is diacylglycerol, and IP3, that is inocetyl triphosphate. Now the DAG causes the sequential events. IP3 increases intracellular calcium. The intracellular calcium along with the guanosine triphosphate and kinases causes contractile elements, actin polymers to assemble, and with help of the pseudopause, the WBC move towards the site. Besides, chemotactic factors also cause leukocyte activation and induce secretion by lysosomal enzymes, production of the arachidonic acid metabolites, and modulation of the leukocyte adhesion molecules. Phagocytosis and degranulation. This is the fourth event. When the WBCs reach the site of the injury, phagocytosis and degranulation takes place. Phagocytosis involves recognition of the particle, engulfment, killing and degrading of the ingested material. So recognition of the particle that takes place with the help of the opsonins. The process of the coating a microbe to target it for ingestion is called opsonization. The substances are called opsonins. The opsonins are the antibodies, immunoglobulin G, specific for that particle, C3b fragment of complement, and binding lectins called collectins. The binding of the opsonized particle to leukocyte FC and C3 receptors promote phagocytosis of the cells and activates the cells. Receptors on surface of leukocytes recognize bacterial, lipids, lipopolysaccharides through kinases. G protein coupled receptors also help to recognize bacterial peptides. When these microorganisms are opsonized, they facilitate the engulfment and then degradation. Engulfment takes place with help of the pseudopores the vesicle form fuses with lysosomal granule, which results in its degranulation. Then degranulation of the lysosomal granule takes place. Steps in phagocytosis, that is adherence or the binding, ingestion to form phagosome, fusion of lysosome forming phagolysosome, degradation with release of the contents and killing of the residual body. So this is the phagocytosis, the picture showing how the cell engulfs the particle and kills it. Phagocytosis depends on the polymerization of actin filament, cytoskeletal changes. Lastly, the microbes have to kill and the degraded within the neutrophil and macrophages by what is called oxidative burst or ROS, that is reactive oxygen species, where there is increased O2 consumption, increased glucose oxidation, glycogen catabolism and reactive oxygen metabolites. So from oxygen plus NADPH superoxide is produced. With superoxide plus hydrogen, H2O2 is produced, hydrogen peroxide, that reacts with chloride forming the HOCl. HOCl kills bacteria and lipid and protein are produced. The enzyme myeloperoxidase, MPO, present in the acidophilic granules of the neutrophils also help to convert the H2O2 to HOCl. That is called H2O2 MPO halide system. NO also participates in microbial cleaning. Nitric oxide reacts with the superoxides to produce highly reactive free radicals. These O2 and N2 radicals damage lipids, proteins and nucleic acids of microbes, thereby killing them. Others are lysosomes, major basic proteins in eosinophils, defensins by forming the holes in microorganisms can also kill the microbes. So this is a microscopic picture. You can see the edematous and neutrophilic infiltration and the monocytes and macrophages. And these are the events that is in days, particularly in the chronic inflammation. Edema, neutrophils, monocyte and macrophage. After certain days, the chronic inflammatory processes, there is monocytes and macrophages rather than neutrophils. Neutrophils you will see particularly in acute inflammatory conditions. So these are the certain MCQs. The sequence of the events in response to an injurious agent is called, the answer is A, pathogenesis. The fifth sign of the inflammation, that is functionalism, was given by, the answer is B, Rudolf Virchow. Interstitial fluid connection during acute inflammation is called, the answer is B, exudate. Earliest event in acute inflammation, the answer is A, vasodilatation. Following are the cardinal signs of acute inflammation, except, the answer is B, arbor. There is calor, rubor, tumor, dolor. No arbor. There is nothing like arbor. Specific gravity of transudate is, so transudate has less specific gravity. The answer is B, 1.0 to 1.012. So this is the end of the today's lecture. We will see the rest of the inflammation in the next lecture. Thank you.